So where we are with these trial results now, when we have seen the results of these trials, we can answer some questions. First of all, in the hot tumors, the green ones, the DMMR tumors, we have seen substantial, unprecedented benefit of addition of immune checkpoint inhibitors to chemotherapy. For I can give you an example from Ruby trial, which I had privilege to lead. Now, we have seen that the patients uh, at 24 months, you have to have a cutoff to see how the results are. The patients who received chemotherapy alone, only 15% of these patients were relapse free. And these are the patients who had primary disease stage 3 or 4 or first relapse, where we should give carboplatin paclitaxel. So these all patients received carboplatin paclitaxel. On top of that, half of the patients received dostarlimab on top of that, which is immune therapy. Others did not, they just received placebo. And we can see carboplatin paclitaxel arm at 2 years, only 15%, 17% who were relapse free. While those who received dostarlimab on top of that, more than 60% patients have a relapse free. And we can see that after 1 year, there are no relapses occurring, very few relapses occurring. It's telling us that we are probably curing this disease and we have tremendous benefit. 4 times more patients are relapse free. When we looked at the overall survival, we saw the same 70% risk reduction of death due to endometrial cancer if we add dostarlimab to chemotherapy. So these all trials, a 10 trial, GY018 trial, DuoE trial, and Ruby trial, these all trials have shown the same benefit, huge benefit. Then the question was, will addition of PARP on top of that will help us even more? We don't really see that PARP is addition of PARP is helping here. And there were some old studies which said that type of mutation in the cell may dictate if patient is responding to immune therapy or not. Now we have 2 huge trials, the GY018 and Ruby trial, both have performed this analysis and have shown that both type of patients are equally benefiting from the treatment. So that is the hot tumors. Let's take the so-called cold tumors. And there we have this small group, 1-2% of poly. These patients do not relapse. So I don't know if we need to give any expensive treatment to these patients. They will not relapse. So we can try to de-escalate treatment on those. What about all others? In all others, we performed the P53 analysis. Those who were abnormal, P53 abnormal, the ones you saw in the red ones, there we saw a substantial benefit of addition of chemotherapy and substantial benefit of addition of both, of immune therapy and both immune and PARP inhibitors. So these are the patients where we are getting a huge benefit of addition of both immune therapy and immune and PARP inhibitors, and probably this is the new standard of care for these patients. When it comes to the NSMP population, again, we see some benefit, but it's too early to answer that question because these patients do not relapse very quickly, so we have to wait for a long-term data. So now we have established that both in the DMMR and NMMRP, we see benefit of addition of immune therapy. Of course, the benefit is unprecedented in the DMMR population, which is the hot tumors. In the PMMR, it's a very heterogeneous group. We have to still figure out which of the subpopulation is benefiting the most, but there is a modest benefit in this population as well.